Hello, and welcome to another edition of Education is the Best Medicine, and thanks for watching. Today's a show on a silent killer, hepatitis C. And after I introduce my guest to you, you're going to understand how important we think this disease is. Hepatitis C is a silent epidemic. It is a liver disease caused by the virus hepatitis C. We have just now understood that its diagnosis and treatment, particularly in people of color, has been lack thereof. Underdiagnosed, undertreated, under-evaluated. My good friend Kirk, who's also a PA, has come today to talk to us about the disease hepatitis C, and I want to again thank him in hindsight for coming. Kirk,
oh, thank you.
Welcome.
Not a problem.
Kirk, tell us a little bit about hepatitis C and why the concern.
Well, like you said, hepatitis C is a viral infection of the liver. It causes inflammation of the liver and cell death. There is a worldwide epidemic of hepatitis C. 170 million people in the world have hepatitis C. In the United States, there's an estimated 4 million people that have come in contact with hepatitis C. 2.7 million of them have become chronic carriers. So you can see that this is a formidable disease that needs to be dealt with. And like you said, in a sense, it really is truly a silent killer because there isn't that much widespread information in regards to it as far as like HIV would be. In fact, the infection of hepatitis C far exceeds HIV by now. Particularly, you know, like the CDC is really concerned and really worried. They're estimating a 4-fold increase of the number of people with chronic infection between 1990 and 2005. So if you have 2.7 million people now that are chronic carriers, by 2005 you're going to have over 10 million people that are chronic carriers of hepatitis C.
Tell us a little bit about the signs of the disease, the symptoms of the disease, and the fact that we do consider this a silent epidemic.
Well, surprisingly enough, you know, for hepatitis C, 70% of the people that contract it don't know they have it. They don't manifest any symptoms whatsoever. Another maybe 10 to 20% would think they had a cold or a flu. You know, and
fatigue is real big too.
Fatigue, you know, they would exhibit symptoms like a flu, malaise, body aches, flu-like symptoms. So again, you wouldn't think that you had a chronic infective disease. You would think you just had the flu that you would get over. And then there's a few people that, you know, maybe 5 to 10% of the people that contracted these would actually get some jaundice, nausea and vomiting.
Jaundice is yellowing of the skin?
Correct.
Yeah. I guess, too, what are some of the risk groups? I know African-American men seem to be high in terms of risk group. What are some of the other risk groups that you're finding?
Well, definitely, that's most definitely true. So let me just kind of break it down like this. Anybody who had a blood transfusion prior to 1992, before the hepatitis C was known, it used to be known as non-A, non-B. In 1989, it was actually discovered and it was classified as hepatitis C. Hemophiliacs, injection drug users.
The sexual partners of injection drug users to a small extent?
To a small extent. We'll get back to it a little bit. I mean, hepatitis both B and C, as well as I think it's G rather, are transmitted sexually, but hepatitis C in actuality is only transmitted sexually to a very small amount. Mm-hmm. If you have a heterosexual partner and you're monogamous, the risk is 3 to 6%.
So most of it is from intravenous drug use that you're
correct. 70-90% of people with hepatitis C are intravenous drug users.
No, I think that also what has been my concern is that the United States Practice Task Force has stated that most clinicians, unless this disease shows some symptoms, should not be screening for it. What's your feeling on that?
Oh, I totally disagree with that. Well, let's use Alameda County. Alameda County has 20,000 using addicts. Not all of those are injecting drug users, but a majority of them are. In Alameda County, you have 9 narcotics treatment programs or methadone replacement programs for these addicts, and I actually work in one and have worked in 3 others over the last 7 years. And I kept my own statistics, and one of the not qualifying, but history questions that we would ask is if these persons had hepatitis C. 70% of the people, or 70 to 75% of the people that I have seen and done intakes on that come into narcotics treatment program are positive for Hep C. That's humongous. That's a huge number of people.
And this is not a new disease, as we noted. It's been noted and recorded for since the time of Hippocrates, and as well as in Babylonia, that this has been a discussion about the liver disease. In terms of the signs and symptoms, asymptomatic, most of the time have some flu-like symptoms. How do you diagnose the disease? What are some of the ways that we can find out if I do have hepatitis C or someone has hepatitis C?
If you came in to see me, the first thing I do is take a history from you and find out what your risk factors are. Are you an injecting drug user? Do you have a partner that has hepatitis C? You know, what your risk factors are. Do you use drugs and you inhale them or inject them? Those kinds of things. Have you had a blood transfusion? Have you had an organ transplant? Any of those kinds of things. I would take that first history. Second thing I would do would be run what we call an antibody test called an anti-HCV test. If that test came back positive, that's not confirmatory that you actually have chronic persistent hepatitis C. It just means merely that your body has responded to an exposure to hepatitis C, which you could have possibly eradicated by yourself, but that doesn't happen very much in Afro-Americans. You see that more among Asians and Caucasians than you do African-Americans.
And African-Americans count for 22% of the estimated 2.7 million people infected in the U.S., and I think those numbers have even grown since I saw them.
Which is, unfortunately, yes.
As folks, what are some of the basic tests that you would get in terms of diagnosing hepatitis C?
Well, first, when they come in, I run the antibody test on them. If that's positive, then I do a confirmatory test called an HCV PCR RNA. That test tells me if a person is replicating the virus in their bloodstream. And usually, it's an indication of chronic persistent hepatitis C. Okay. After that information, along with some counseling, because that's not very good news, I would run a battery of tests on the patient to find out where they're at, namely a CBC, complete blood count, TSH. I would run
thyroid test.
Thyroid test, correct. I would run what we call an alpha-fetoprotein, non-maternal, which would tell me if they're developing a tumor, because 10% of the people with chronic hepatitis C can develop hepatocellular carcinoma. I would run
or cirrhosis, right?
Or cirrhosis. Well, actually, it's more specific to hepatocellular carcinoma.
Okay.
And then I would order things like an ultrasound to also look for tumor or fatty liver or fibrosis. Liver biopsy, that's definitive. And a few other tests that would give me a general idea of the patient's general health.
Yeah. Well, again, we are both physician's assistants in the community. And first of all, I want to thank you for coming on and sharing some of your vast reservoir of knowledge. I think this is the first in the discussions that we'll be having about this disease. I think it's one of the diseases that have been underdiagnosed, undertreated, and underevaluated in our community. And again, I want to thank you for coming on.
I want to thank you for having me.
What got you interested in hepatitis C?
Exactly what I said. When I was working in a narcotics treatment program, basically what would happen is patients, we were allowed to do intakes on them and find out what problems they had, and we would refer them out for those problems. Most people who are having problems with illicit drugs or have become addicted to drugs do not follow up. If I send them down the road to get their abscesses lanced, they never make it. If I have to send them to mental health services, because 50% of people that have addiction problems have also mental health illnesses, they never make it. Okay. So, and all I saw us doing was bring them in, intake them and dose them on a daily basis, but never address their other needs. And that really, really bothered me. I truly believe that anybody who has medical problems should have the same access to healthcare that me and you would have. If me and you got sick with hepatitis C or anything else, we would have the best there is at our disposal. And I think that anybody else should have that opportunity.
Okay. We talked a little bit about the biopsy, which is a definitive diagnosis for hepatitis C. A lot of concerns around that procedure And what can you tell our audience about the fact that the need to have that procedure?
Well, it would depend a lot on what was going on and where you were at. If you came in and you'd had, let's say that the disease progression of chronic persistent hepatitis C runs anywhere from 20 to 30 years. It is very, your words of a silent killer is very, very true. You don't even know that you're having it. But all along in this period of time, it is causing damage in your liver to the point of what we call fibrosis, which is scarring of the liver, to cirrhosis, which is severe scarring of the liver, and death of actual liver tissue, so that now the liver is becoming decompensated because there's not enough tissue to do what its normal function is to do. So basically, depending on where you're at and depending on if you're seeking treatment, most hepatologists and gastroenterologists need to have a definitive idea of exactly where your liver is at, and liver biopsy is definitive. It will tell you how much scarring, how much inflammation, and the disease progression, and where you're at as far as in the progression of the disease.
And that brings my point is that one, hepatitis is probably the most common bloodborne infection in North America, and also the need for specialty care. You mentioned hepatologists and gastroenterologists. How important are they in managing this disease and in a partnership with the primary care provider?
They're critical. Although most gastroenterologists and hepatologists would like to see more primary care physicians treating people with hep C, right now that's kind of not the case. They're referring back to the gastroenterologists and hepatologists because treatment for hepatitis C is a horrendous treatment. Depending on the genotype that you have, the most prevalent genotypes in the United States are genotypes 1, 2, and 3. And depending on if you have one, which is the hardest to treat, and the most prevalent in Afro-Americans. Okay. And also Afro-Americans do not respond to treatment as other ethnic groups like Latinos, Caucasians, or Asians do.
Is there any reason why that is?
They do not know. There are studies being done right now to try to find out why African Americans do not respond as much as the other groups do.
And we tend to dominate. Ways of monitoring the disease through treatment. I hear viral load, those kind of things. What are some of the ways we can monitor liver function states? What are some of the ways we can monitor to ensure that one, treatment is adequate, and two, folks are responding to treatment?
Well, as far as liver function studies go, and as far as viral load goes, they are not diagnostic of progression of the disease. They are mainly used as tools in treatment of disease. Now, you know, because you can have progression of the disease in your ALT, which is alanine aminotransferase, is an enzyme that is indicative of liver cells dying and they leach out into the blood, and so we can monitor that. It's called ALT.
Right.
But many people can have a normal ALT and still have disease progression. You can have somebody who has a high viral load and he has no disease progression going on at that point in time, or you can have somebody who has a low viral load and they have a very high amount of disease progression going on in their liver. So we do not use those as markers of progression of the disease. We more use them as indicators of treatment of the disease. Is the treatment working?
I wanted to piggyback on something too. You talked about access to care, and we really find that folks that are incarcerated, homeless, and women are not getting in for care. Is there any particular reason why you think that is so, or is it again an issue of being underdiagnosed, undertreated, and underevaluated?
Well, when you talk about the incarcerated population, and to back up a little bit and say what you all said, the number I gave you of 2.7 million people in the United States is not really a true number, because the homeless, the indigent, and the incarcerated and people that are also in mental institutions are not counted in that number. Right. So the number of people with chronic infection is actually higher. But to answer your question, they don't have access because the government's not going to pay for that. They're not going to. I mean, it's like the problem that I face here in East Oakland. If you're a black male between the ages of 18 and 26, and you don't have a child in your home, you have no job, you have no access to Medi-Cal. You have no access to any kind of healthcare system whatsoever. So, and the cost of just running screening lab work is probably well over $3,000. So if you don't have the funds to pay for that, okay, or the means to pay for that, you can't even get evaluated.
You know, and I also think that it brings to a larger question of our need to, one, bring voices to communities that don't have a voice. And that's one of the reasons we wanted to have you on, because I felt, and we had talked about this earlier, that there has not been enough media attention to the disease hepatitis C. It is not one. It's not a healthcare concern, a public health concern that's on the radar, unless it's underdiagnosing us and undertreating us. So again, I think that this is one of the reasons that we wanted to have you on, because you're where the rubber meets the road. And again, tell me a little bit about the program that you are now involved in and running. We first met at a hepatitis C training seminar called Train the Trainers.
Correct.
Tell us a little bit about that program and how that got started and the aims and goals of it.
Train the Trainer program is a program that was initiated and started by hcvadvocate.org. You can go on the website and find them at www.hcvadvocate.org. I would suggest that anybody that has a computer and you want information about hepatitis C to go to that website. It is one of the best and most comprehensive websites in relationship to information in a simplistic form about hepatitis C that you can possibly find. That website is published and run, and the organization is run by Alan Franciscus, who is also responsible for the Train the Trainer program that me and you took. The Train the Trainer program is a program where you teach individuals about hepatitis C who go out and teach other individuals about hepatitis C who go out and teach other individuals about hepatitis C. So you break down all the barriers of misinformation, about no knowledge whatsoever, and you start educating people about the disease of hepatitis C. It's an excellent, excellent program.
How do we get a hold of you?
Oh, you can get a hold of me through my email at kirk@aceffort.com. We're also located at 9502 International Boulevard in East Oakland. The programs that we present, that we have right now, is twice a month, bi-monthly. We hold hepatitis C education and information sessions open to anybody for an hour and a half. They run from 6:30 to 8 o'clock on Mondays. We also have a hepatitis C support group for people who do have hepatitis C, for their loved ones or anyone that wants information about it. And we also run a hepatitis C pre-treatment protocol where I will diagnose, evaluate, and put you in a protocol for 12 months to help you get ready to be able to be treated for hepatitis C, if that is your wish.
I think that also, as you spoke to the global epidemic, we see more communities, particularly the Pacific Rim and European countries and Russia, being affected with hepatitis C. The new immigrant being hepatitis C. And I also, from a review of literature, understood that more gay men have hepatitis C. And that's a discussion that we need to be having about, again, about the global picture and the diverse nature of this disease and who is it affecting. I also said that women are being inordinately affected and not being diagnosed, not being treated. And I think that that's a concern. Could you speak to some of those concerns?
Well, when you were talking earlier about sexual transmission, there is evidence that suggests that transmission from male to female is much more efficient than from female to male, from female to male. There is no studies that have been done or any evidence that suggests that women to women transmission is adequate or efficient unless they're menstruating at the time. There is also some evidence to support that that anal sex is also an efficient way of spreading hepatitis C. So clearly, you know, it can be spread that way, but specifically for hepatitis C, the most common way is blood-to-blood contact. Mm-hmm. You know what I mean? So during those forms of sexual activity, you know, obviously a condom. Please use a condom. They can be spread.
Yeah. A little bit about treatments. What are the treatments that are on the market? We talk about the fact that African American men and African Americans in general tend to be a little bit resistant to treatment because of the genotype. What are some of the treatments that are out there now, and could you talk a little bit about the concept of combination therapy? Okay,
well, basically, we have always treated hepatitis C with interferon. Interferon is a naturally occurring enzyme in your body that fights viruses. And what two companies have done, one is Roche, the other is Shearing Plow, as have developed interferon now in a pegylated form, where it stays in your body a lot longer so that it's working a lot longer against killing the virus.
Oh, we would say fillet, but it's pegylated.
Yeah, it's
okay.
pegylated.
Okay.
It's pegylated.
Okay.
Roche's drug is a pegylated interferon alpha 2A, alpha 2B, and it is called Pegasus. And Shearing's drug is called Peginteron. It's a pegylated alpha interferon alpha 2A. Basically, they put those in combination with ribavirin, which is another drug that we use in combination therapy, and they've had great success. Like I said earlier, well, maybe I didn't, but the sustained viral responses that they're getting now in people are anywhere between 40 and 50%. Now, if you have genotype 2, that's in genotype 1. If you have genotype 2 or 3, the sustained viral response is anywhere from 80 to 90%. So it's better to have genotype 2 or 3 than it is to have type 1.
Well, even they're finding now, as a review of the literature, that the longer treatments are tend to happen. And so it's just not the treatment, but the length of the treatment. Could you speak on that a little bit?
Yeah, and typically in genotype 1, length of treatment is 48 weeks long. In genotypes 2 and 3, it's 24 weeks long. Because the response is much better and much quicker.
So the class of relapse and non-responders, what is going on with that particular population, if anything?
Well, with the non-responder, first you have to look at, which drug did he not respond to. And before, they used to give a lot of monotherapy, where they just used interferon, and it was just, alpha interferon. They weren't pegylated at all. So a lot of those people are being evaluated for retreatment with either Pegasus or Peginteron. Okay? Again, as far as treatment goes, it depends on where you're at. Some people, some people may not opt for treatment right now because the disease progression is either very mild or very limited. And the treatment with these drugs is actually very horrendous. It's very much like chemotherapy. You get very, very sick. It produces a profound depression, so profound enough that people become suicidal.
And I was going to ask you some of the side effects of these
Well, suicide, fatigue, malaise, joint aches,
Anemia?
Fever. Pardon?
Anemia. Yeah.
Definitely with ribavirin, anemia. And you're sick constantly, for a year, because with both drugs, you give yourself the injection of the pegylated interferon once a week, and you're taking ribavirin 3 times a day. You know what I mean? So it's a horrendous treatment, and you need to have a lot of support.
And my whole discussion, I think, with this is saying that if you cannot tolerate the treatment, or if you can tolerate the treatment, it will probably save you the attempt to get on a liver program and get a replacement liver, because those particular first of all, there's not enough livers, and secondly, you can't get on these lists long enough, and by the time you're on them, you've already succumbed to the disease. Or
very much, or you've got serious sequela, and you're literally at end-stage liver disease, and that's agreed. And it's very true. People who have hepatitis C think they have hepatitis C. They need Black Americans, if they're not getting evaluated, they need evaluation, because what you said is very, very true. Number one, getting on a list. I mean, it's not like just going up and putting your name on a list. There's a huge evaluation for that process, and it's very, very, very limited, the number of livers.
Some very famous people, I think Walter Payton tried to get on the liver list and by the time he got on, he wasn't able to get the liver. So we are having a discussion, one, about evaluation, about treatment, about early diagnosis. There is therapy out there. The therapy does have a lot of side effects, but it beats trying to get on a liver list to get a new liver. The expense and cost will be handled, if you have insurance, by insurance, which brings me to mind, does insurance cover this?
Actually, yes, some insurances do cover this. And I speak mostly to those who have problems with addiction, okay, because that's who I see most of the time. Right. So, and those kinds of resources and those kinds of situations, when we have individuals who are truly showing a willingness to change their lives and stay clean, there are methods that we can use to help them get the medication that they need. We can get grants from Roche or sharing to treat them. There are ways to do that, but those people would really have to be individuals that have been involved in a program of like Narcotics Anonymous and being clean and having other parameters of their life, socially, economically, et cetera, work through for them and establish for them so that they can get treatment. So treatment is available. As far as, those who have health insurance, obviously treatment is available.
Okay. Alcohol use.
None. If you've got
none.
zero,
nada.
zilch,
Okay.
none. If you have hepatitis C, do not drink.
Okay.
Period.
All right.
The average, even for people who are just trying to stay healthy and have a healthy liver, no more for men, no more than 2 drinks a day. No, for women, no more than 1.
Because there's been some discussions around the health benefits of alcohol, but with a disease like this, it's probably best not to.
Best not to is not the word.
It's not to.
It's not to.
Okay, all right, not to.
I mean, period. There's no question about that.
And we also say that too, that I think this is just not a disease it's a disease of economics, food, clothing, and shelter, access. And we think by you coming on today, it provides us with a discussion and a medium to have us understand this disease better. What do you think are some of the major myths as we kind of wind down with the disease hepatitis C?
That it can't be treated. Most of the people that come into my sessions don't even know that there's a treatment. They've gone to their doctor, he's taken their liver enzymes and their ALTs are normal and he says you're fine. Well, that's a lie. They're not fine. We don't judge progression of the disease based on whether you have normal ALTs or not.
Right.
So there's a whole lot of misinformation going on out there. Also, there's a lot of misinformation about the treatment itself. But the biggest thing that I found is most people don't even know there is a treatment.
Why do you think there's so much watchful waiting with this disease as we kind of close this down?
Watchful waiting by what, the actual person that has it, or watchful waiting by the government, or?
By excuse me, my understanding is that it's not as aggressive. We're not approaching diseases as aggressively as we need to. Thereby, we kind of lull our patients into a sense of saying that, well, the disease is like 20 or 30 years. When you come back and start having symptoms, then we'll take care of it.
I think it always boils down to the same thing. It always boils down to money, and the expense and the burden that it would put on the country, or the community, or the county, or whatever. The annual loss from hepatitis C right now is greater than $600 million a year. So you can imagine trying to treat. And what's happening is all of the people who have contracted hepatitis C and had it for 20 or 30 years, and now are getting to be in their 4th and 5th decade, are now coming into the hospitals, sick, needing livers, blah, blah, blah. So the burden is increasing.
Kirk, this has been exciting. I'm glad I met you. I want to thank you for bringing light to a very dark world. And if vision is the art of seeing things yet unseen, you truly are a visionary. Thank you for gracing our presence and providing such information. I want to have you come back. I want to partner with you. I think that you provide a wealth of information that the common individual like myself needs to understand and know. Thank you very much for coming on.
Thank you very much for having me. It's been my pleasure.
My pleasure.
I feel honored that you asked me. Thank you.
Thank you. It's really interesting that this disease really hasn't been dealt with in the way it needs to be dealt with. And as soon as
from mamas broken hearted, I surely came. Sons that were slain for minimal gain. Youth that can't read, speech that can't talk. Passion to move, but love that won't walk. I speak to you, my heart and my soul. My family and folks who I surely owe. My 100 double O, nigga, ride a flow to the beat, here we go. And it's so. I was born in the city of dope. If you survive with the live, gotta pray to cope. When the players pop the colors on the fade stroke. 76 keys of F3, I'm ready to go. To the land with the haters, backhand. Understand the plan. Happiness comes in dimes to grab. Even L7 boys got them cell phones chipped up with